Welcome to this episode of the Frank and Lizzie Show. We are so honored today to have a really innovative technology that has come to the market. Frank, how are you doing?
Better, recuperating, but I'm going to tell you, there's a lot of talk about lymphedema, venous disease at every conference that I attend. So this product is right up my alley.
Yeah, for sure. So, few things. I know I just heard you speak at Wound Week in Philadelphia for the APWCA. And I know before that you were at AVLS. But this product, we actually saw at another conference in the spring. And I had to do a double take because I saw a woman touching your thigh. And I thought, Frank, what are you doing? Not in a professional conference setting. Can you tell me what was going on?
Let me explain to clarify. We have I guess, a need because when we put patients on multi-layer at the lower extremity, I still have to compress the thigh. So when I saw this product, I thought maybe this is going to meet the needs that I'm looking for. And so you caught us as she was applying the product because I was interested in it. So,
Okay, wow. I want to hear more about what this product is, what it's used for, how we get it. And we actually have the honor of having not one, not two, but three guests on today's episode, which is awesome. So, first and foremost, let me introduce Dr. Alton Johnson, who is a podiatrist at the University of Michigan Medical School. Welcome, Dr. Johnson.
Thank you for having me, guys.
Yeah.
and then we have Dr. Traci Kimball MD, and she does have her MBA. She's out of Denver, Colorado. She specializes in general surgery with a specialty in vascular and also geriatric. And she's a wound care specialist as well.
Thank you for having me today.
And last but not least, we have Kim Rozman, who is a MSN RN CWON, who's the clinical program manager for Wound Express from Huntleigh.
Thank you so much for having me today. We're really excited to talk about this product.
Great. Well, first and foremost, what is the product? Tell us.
So we have Wound Express, which is an innovative thigh-applied intermittent pneumatic compression device. And so we're really excited to talk about it because it is something totally different and new, where we compress the thigh away from the wound to improve lower extremity wound healing.
That's so interesting. My first job in wound care 16 years ago, we had a recliner room and it was intermittent pneumatic compression therapy. And we would put boots on their legs and have them up before rewrapping them. And one of the problems that a lot of our patients talked about was they couldn't get the boots on themselves because they couldn't bend over far enough to get that on. And so it seems like that would be a great thing to replace that. But, Dr. Johnson, what data do we have to support this, the use of this device?
Just thiopide alone. So, there is a current study that Kim will touch on that they're collecting data on. But in pneumatic, ICP in general, which is pneumatic, intermittent pneumatic compression itself, IPC, sorry, in general, shows that, it can help with what they call arterial blood flow and venous congestion, which aids in the wound healing process of the lower extremity. There is, like I said, there is current studies being conducted for thigh only, and Kim can comment on that with her company is currently collecting and some of the data that's been released.
Yeah, Dr. Kimmel, why don't you tell us a little bit more about some of the data that we can expect to see upcoming here?
So Huntleigh and Arjo have collaborating with international companies to enroll patients in a prospective trial in Europe and the United States with the help of the Serena Group. We'll touch a little bit on some of the historic information that back in 2004, Morris researched that the hyperemic response in the calf in these patients with full garments from the ankle to the thigh work to find the optimal compression timing to produce the best hyperemic response, which then informed the creation of the Wound Express device, which of course is different in that it's applied to just the thigh instead of the entire leg. Well, what is a hyperemic response, Dr. Johnson? Tell us a little bit about that.
So typically, as a podiatrist, we always debate about hyperemic response versus actual like cellulitis presentation because it actually looks the same when you have it. But our true hyperemic response is that relief through that venous congestion that allows essentially the lymphedema, the lymphatic fluids to be freely floating, unlike when those valves are kind of congested. And it actually helps with the rebound response of the lower extremity, which kind of indirectly or directly aids with the wound healing process that occurs in these individuals. But yeah, so a lot of people, you'll hear people come in and say, oh, patient has cellulitis after either undergoing a pneumatic compression or actually going through manual compression, which Frank knows because he also is a specialist in it. But that is the hyperemic response, and also helping with those waveforms that aid with the congestion and the perfusion of the lower extremity.
I just wanted to comment once with that hyperemic response, you are compressing the thigh in our device for 2 minutes, and that is sort of the active compression. And during that time, the venous return is actually improved and drawn up and out the body's natural pathways. But then we have a 2-minute rest period. And during that 2-minute rest period, that's when that hyperemic response occurs, and we have that improvement in the arterial velocity of the blood flow down to the lower extremity, which is, of course, bringing all of that those great nutrients down to the lower extremity to heal the venous leg ulcer or mixed etiology ulcer.
You bring up a really good point, and I'd like to just tut in here and say that because I just kind of had the aha moment, which would be really interesting to see potentially in some animal studies or even human consented biopsies, is that with your compression to subdiastolic pressures and the enhancement of the arterial velocity, I'm almost wondering if you're coaching the body to create new byways and highways around stenoses that are in the major arteries. So you might be actually helping patients learn how to compensate for PAD that they already have. So not only are you enhancing the venous return of the calf, but you're also potentially helping with the enhancement of arterial delivery and outflow in the calf as well, which for these mixed etiology ulcers may be actually the reason why we see such great improvement.
Yeah, I agree. That'd be cool if they actually biopsied so we could see if they're getting like a VEGF response. Because I don't even know if that's been done. That's true.
Lots of things to elucidate.
We have so much to study. It's very exciting.
Yeah, and the one thing I want to add, even using ICG green fluorescent imaging, I think that would show, because we did a study recently and it was amazing to see the lymphatic system. But when you look at how much pressure you have, it's not a lymphatic capillary closing pressure. Belgrado said, I think it's about 76 to 80 millimeters of mercury, and your product doesn't get over that. So
yes, the product sequentially compresses at 60 millimeters of mercury with 3 segments. It applies just like you would apply a blood pressure cuff, so it's super easy for the patients to apply. And then it's literally just a button that they press to turn the pump on. It's a very, very simple device for our patients to use and utilize, and they find it to be extremely comfortable.
So when you say your patients, who are your patients? Do we use it in venous leg ulcers? Do we use it in lymphedema patients? What if they have lipedema, lobules? Tell me more about who's our target patient population and who gets payment for it.
We are driven by a HCPCS code, which is EO651. And so there are 2 different types of patients that are optimal for this device. Our device is best used for patients with chronic venous insufficiency, with phlebolymphedema, with venous leg ulcers, and mixed etiology ulcers. And so these patients have trouble putting on full leg garments because then those garments squeeze over the wound site and cause pain. And so I have a home health. I used to do home health and hospice with patients, and I would walk into the homes and the lymphedema pumps were sitting in the corner because they didn't want to put them on. And so this product is something that's easy to apply. It doesn't cause pain, and in fact, 83% of our patients have found that they reduce pain while they're using this product. And I just wanted to comment that, we have 1% of our US population has venous leg ulcers. Greater than 50% don't heal within 1 year. And we spend about $15 billion a year in treating venous leg ulcers and chronic venous insufficiency and phlebolymphedema. And so we need something that can work in conjunction with our standard of care dressings and that gold standard in order to augment and enhance the blood flow.
Yeah, and Liz, we didn't have a relaxation room like you did way back then.
It
With a
wasn't
recliner and
relaxation,
drink.
it's recliner room.
Recliner.
But here's the thing that we try to put people on compression, and we may change them twice a week. I mean, most of my patients I try to get to once a week, and they're doing this at home. And a lot of the companies may say that you can't apply a full length garment over compression. It's just not effective. And so this is why I had Kim put this thigh piece over my thigh. So
And Frank, did you find that it was soothing and comfortable to wear?
yes, it was easy to apply. The other garments usually you have to be able to have a little flexibility. So it was easy to apply. So I'm dying to try it, by the way.
Some of our patients have just some body habitus issues where they have trouble bending over and putting on these large garments. They have trouble with dexterity to zip up the garments and all of the different ways that you apply a larger garment. And so what we're finding with our patient population is just easy to use and something that they enjoy using.
All right. So let me hear more about how do I actually get this for my patients then?
Alrighty, so there are two reimbursement pathways for EO 651 or Wound Express. There's the chronic venous insufficiency pathway, and there is the lymphedema pathway. Per CMS guidelines, if you have chronic venous insufficiency and a venous leg ulcer, you have to wait 6 months and fail standard of care therapy prior to access to intermittent pneumatic compression devices. Along with that, you also have to provide a med list. You have to document the failure of the 6 months of standard of care. And there's a whole, of course, host of list of things that need to be placed in the medical documentation and the clinical documentation in order to get this treatment. However, if your patient has phlebolymphedema, that patient qualifies for the lymphedema pathway. The lymphedema pathway, the patients have to fail standard of care for 4 weeks, and then they have access to IPC.
Wonderful.
This is exciting.
So, what is phlebolymphedema? Do your Alton and Traci, do you document phlebolymphedema in your notes?
Yeah, let me go first, and then I'll let Dr. Kimball hit it off because I know she loves that. She loves this more. She loves it more than me because she does. So yeah, yes, I definitely have to document it because let's say I'll just go for example. I mean, anytime I go and order a IPC, the therapist, which usually we have an occupational therapist that aids me with the orders because, like I said, I'm not as proficient in the lower extremity compression realm. And most of the time I don't have enough descriptors to describe it. And it's and that's why the insurance usually denies my claims. And Dr. Kimball kind of explained to you what needs to be documented, but don't make the same errors as me and just say, +2 non-impeding edema and think that's going to get it covered. It's a little bit more to it than that.
Thank you, Alton, and thank you, Kim. I think it's really important for us to really teach physical exam findings that what one needs to look for, and be familiar with some of the terminology. And something that I, of course, learned during this practice and experiential specialty was the Kaposi stemmer sign. It's the inability to tent the skin between the toes. I always just called them sausage toes, but essentially taking your index finger and your thumb and trying to pinch the second toe, and basically not able to actually tent the skin is a positive stemmer sign, would be a sign of lymphedema. Obviously, chronic venous insufficiency is a pathologic description of the veins not having the appropriate mechanism of action to return and restore blood flow to the central part of the body from the limb through valvular deficiency. Lots of times we see stigmata or symptoms of CVI because the patient has a brawny edema. So they may not even have pitting edema, but brawny changes is this hue, easier to see, and higher, lower Fitzgerald scores. So patients with high melanin content might be more difficult to see, but or they might tell you, why is my skin getting darker there? And will it ever go away? I've never had sunburn there. I don't know what's going on. And those are signs of hemosiderin deposition. So the fragility of the blood vessels in the microcirculation and the capillaries, because of this elevated pressure due to chronic venous insufficiency, causes breakage and bleeding into the soft tissue, which leaves that ferritin or hemosiderin coloration. For lymphatic insufficiency, not only do we have the stemmer sign, but we also look for dorsal foot mound, medial lateral foot mounds as well. Corona radiata, which is striae or microangiotic changes around the ankle. Again, some more stigmata of these disease process. But the most telling, and something that actually is a slam dunk diagnosis, is lipodermatosclerosis. And lipodermatosclerosis is imaged here on the left side or right side of the screen. And that is an upside down champagne glass appearance. So patients have significant scarring. This patient specifically, a large likely mixed etiology ulcer here with atrophy blanche in the medial aspects, with all that white striation or scarring and stellate appearance of previous wounds and ulceration. Of course, there is open ulceration there towards the anterior or lateral aspects, but then you have the significant scarring at the ankle, and ankle circumference in this patient might actually look normal because of that. But in all reality, this patient's been suffering from both probably chronic venous insufficiency and lymphatic insufficiency for many years, giving them that upside down champagne glass lipodermatosclerosis diagnosis.
That was great. I mean, I know Frank and I did a short on stemmer sign in which my son Kai helped us demonstrate how to properly pinch the toes and document that in order to get that diagnosis. Because you're right, I mean, Mark Moline and Frank always lecture that all edema is lymphedema, and you really just need to prove it for the purposes of that. So, well, this has been hugely helpful. I'm excited to see as these studies come forward what more information we'll get from them. And then I know that Kim will also be providing us with all of the contact information, which you can see here on the screen. So feel free to visit www.huntley-healthcare.us/wound express for more information, or reach out directly to Kim and her team in order to get some more information. Frank, we'll have to see what you think of this once you finally get your hands on it.
I do want to get my hands on it because there's so many different types of modalities out there, and this one would definitely fit the patient population that I see. So I'm curious. So
Well, a thank you to Huntleigh Healthcare, to Kim, to Dr. Johnson, and to Dr. Kimball for being guests on our show today. Thanks so much, guys.